Welcome to Scrambled, your space for fertility, owning your 30s, and the scramble that makes it all worth it.
Welcome back to the podcast, everybody. Today we are very, very lucky to be joined by Cody Thomas. She is an embryologist whose work brings her right to the heart of life's earliest beginnings. Cody holds a master's degree in clinical embryology from Monash University in Australia. And for the past 8 years, she has worked as a part of a leading fertility clinic in Melbourne, Australia. She helps turn possibility into reality for so many families.
We are thrilled to welcome Cody to the podcast, where she will share insight into the remarkable science of embryo and egg freezing. So, Cody, please tell us about yourself and your career.
Thanks so much for having me, guys. This is very exciting.
Very exciting.
So I first studied an undergraduate in science, and it was just very general, and I didn't really know what I wanted to do with it. But I really liked the human development and just learning in general what that was about. And I also really liked genetics. So I kind of started leaning towards more of the biology side of things and eventually reproduction. And while I was deciding where I wanted to take it, I was also really interested in women's health. So it was kind of a natural progression that the two linked up, and it ended up as embryology. So I've done a graduate diploma in reproduction and a master's of clinical embryology, which is super specific and really is only relevant to this one job. But that's the study that I've done to get here.
Amazing. And then what is the difference between egg freezing and IVF to create embryos?
Yeah, so both processes have to start with the same step, which is stimulating the body using hormones to make sure that our ovaries will produce enough eggs for collection. Regardless of which process you're going through, you'll have to go through egg collection. What will happen there is the doctor will use a needle to collect the fluid from the ovaries, the follicles on the ovaries, and then they'll pass that fluid off to an embryologist who will hunt through the fluid, and they will try and locate the eggs that were within those follicles. So once the scientists have the eggs, they then can assess the maturity of those eggs. And if you're doing egg freezing, what they can do is then just snap freeze them on the same day as collection, and they'll stay in that state for as long as you want until you're ready to use them.
What's a snap freeze? Like a
quick
freeze?
Instantaneous freezing. Yeah. So
with what?
Yeah, I know. It's how do we do that? Yeah, it is a little bit complicated, but pretty much what you would do is we want to make sure that we can dehydrate the cells. So we take the fluid that's in the cells out using a process of medias to dehydrate the cells. And because you've removed the water, you've now removed the risk of kind of ice forming within those cells. And then once they're dehydrated and they're kind of replaced with a cryoprotectant that protects the cells from those ice crystals forming, we put them straight into liquid nitrogen, which is at negative 196 degrees Celsius.
Oh, crazy.
Can't remember what that is in Fahrenheit for you, but it's extremely, extremely cold. So by doing that so quickly, we keep the eggs in the exact kind of state and quality that they were when they were collected.
Wow, that's incredible.
Yeah. So alternatively, then, if you are not looking to freeze your eggs and you're ready to create embryos, so you're potentially ready for an embryo transfer, so to have a baby, or perhaps you're looking to store some embryos for future transfers, then to get to the stage where they can become a baby, they need to be first a blastocyst. So we need to fertilize those eggs using sperm, and we can do that on the same day that we collect the eggs, but then we need to grow those eggs to day 5 to when they become a blastocyst, and we can do that in the lab before we then go on to see what their potential will be.
Yeah. One more question. When you say grow, are you doing something each day to grow, or you're just watching them grow?
Yeah, beautifully enough, we don't have to do a lot once we've fertilized the eggs, which is great. So they naturally will go through those developmental processes that they normally would inside the uterus. And we just watch them in the lab. And that gives us a little bit more information. So rather than just putting back a fertilized egg, it gives us a bit more of a selection tool. So we don't really know what an embryo's true potential is until about day 5. Usually late day 4, early day 5 is when they'll start to show us if they've got what it takes to become a usable blastocyst or not. So by culturing them in the lab to day 5, it gives us a little bit more information before we transfer it back, rather than perhaps putting back an earlier, like day 2 embryo, which we're not quite sure where that would have gone yet. So it gives you a little bit more potential information about how successful that blastocyst will be.
Yeah, okay. Can I take us back a couple of days from blastocyst? So we've taken the eggs out of the patient and you guys now have them in the lab. And if you're an egg freezer, we're kind of done there, but you want to create an embryo. So what is the process of fertilization? How do you guys introduce that egg to sperm to create the embryo?
Yeah, so we've got 2 methods. IVF is called natural insemination or conventional insemination, and that's where we let the sperm do a lot of the work itself. So we will still process the semen sample to get it as clean as possible. It also helps reduce the risk of contamination by processing it. And then we let the sperm in a well with the eggs and let them naturally kind of swim up. And it also lets the egg kind of select the sperm in the way that it naturally would in the uterus. Eggs also have this wonderful ability that once one sperm has penetrated, they actually can put up a barrier and they stop other sperm from getting in.
Wow.
Yeah, it's very incredible. So even though we put a whole heap of sperm in there with the eggs, once one has got through to fertilize, it'll stop the others from entering. Whereas with ICSI, we will actually select the individual sperm, and instead of letting it swim up naturally to the egg, we will actually use a needle to put it inside of the egg. So that can be really helpful if, for example, the sperm provider has a very low sperm count. So perhaps they don't have enough sperm to naturally inseminate the eggs, or perhaps it's not swimming very well. So we can kind of bypass a couple of the natural processes and assist in fertilization, which may help in why they're not falling pregnant naturally.
Okay, wow. So with IVF, would you say majority of people are utilizing that ICSI process, or is it more common to do like conventional insemination like you were talking about?
Yeah, so in Australia, it used to be about 50-50. In recent years, we have been leading towards ICSI, so the injection. Like I said, it's overcoming a lot of barriers.
Yeah.
So some people want to jump straight to it rather than risk the chance of failing with IVF.
What would be the downside?
Yeah, so the downside with ICSI is that we are artificially like putting the sperm into the egg. So there could be further problems down the track that we haven't really seen yet. But with this artificial process, it's still quite a new technology in all. So we try to do as little intervention as possible. And obviously that's quite an invasive step. Other than that, there isn't really a downside. We've seen how successful it can be. It can overcome, a lot of male factor or sperm factor infertility reasons, which is great because it's kind of some people, that's all they needed was that initial step to get through the egg.
So would you recommend for someone who is potentially struggling with IVF, they've had a consultation with maybe a doctor about their fertility, is that a conversation that they should be having with their doctor in the initial stages, things about like ICSI versus conventional insemination, to kind of make those decisions on what the plan is going to be once we have those eggs taken out of their body?
Definitely. Yeah, it's the best conversation to have with a fertility specialist first up. Usually before you'll start this process, there'll be a lot of diagnostic testing. So that will include a semen analysis, which will usually give the fertility specialist a good idea of which way we should be leaning. Yeah.
Sure. Okay, that's really cool. So we've done it now. We've got our eggs out. You guys have done your magic in the lab, and we've ended up with hopefully a blastocyst that can become a viable pregnancy potentially in the future. And then all of a sudden you start talking about grading, and people start hearing grading around their embryos, and they're given literally a grade like they're in school. Can you talk us through what is embryo grading?
Yes. So I know that a lot of people hang on the grading too, as they think it's just so important. And if they get a lower grade, they're a little bit disappointed, but it's not the be all and end all. So we use the Gardner grading system, which basically means you'll get a number at the start of the grading, and that number just explains how expanded the embryo is. So at what stage of the blastocyst it's at. So starting from a 1, you've got the initial stages of a blastocyst. So we can just see a small cavity that's forming in the embryo, and it's going to start to expand out, showing us that it's going to hatch out of its outer shell or the zona. And once it does expand and hatch out, it becomes a 6. So all the grading numbers up until that is how expanded the embryo is and what stage it is along that process. Okay, so that's the number at the start. When it gets to a 3, we can start to differentiate the 2 cell types in an embryo. So we have the inner cell mass that becomes the baby, and we have the trophectoderm, so the outer layer, and that becomes the placenta. So when we can start to tell the 2 different cell types apart, then we can start to add the letters in. So the first letter is what you'll get for the ICM, so the inner cell mass. And that's usually graded between an A, B, and C. And the same with the trophectoderm. So how many cells there are and how well compacted those cells are would be an A. And the fewer cells that you have, or the less compaction, you might get more towards a C. But it's just between scientists, sometimes they'll disagree, and someone would call it an A and someone would call it a B. And we get babies from A's and B's all the time. In my lab, we're reluctant to freeze C's because they tend to not have enough cells if they're frozen to survive the thawing process.
Okay.
So we never want to disadvantage a patient by freezing something that we don't believe could become a baby. But in other labs, they will freeze C's, so there's just because you've got a poorer grade doesn't mean that you can't end up with a baby from that embryo.
Yeah. Okay. Interesting.
And this was one of my later questions, and this is also, I guess, one concern I have for myself just with having frozen eggs, but not embryos yet and nothing graded and not knowing how many I'll have in the future. But how are frozen eggs and embryos stored? And then what does that defrosting process look like?
So when we thaw them, we need to rehydrate them. So we'll run them through a series of media that will slowly take out the cryoprotectant that we added, and it will replace it with water. So it starts to kind of bring it back to life by giving it what it needs again, waters and sugars, to make it re-expand. So in the morning when we first thaw them out, they can still be quite compacted, but throughout the day, it'll show us that it's starting to re-expand again, and that's how we know that there's signs of life there and it's survived the process well.
That is so
That is
interesting.
crazy. I mean, and when you say like you're looking at it, you're under a microscope. This is all microscopically being inspected by you guys.
Yeah. So most of the time we're working at like times 10 or times 20 of what your normal eyes would be visualizing. Yeah.
Science, man.
It's crazy. That is crazy.
That does kind of lead me into our next question for you. And that was just going to be like, can you guide us through what a day in the lab looks like for you? I'm sure it probably varies from day to day, but like, what is an overview of an embryologist inside the lab doing on a daily basis?
Yeah, so we start quite early in the morning
Mhm.
because our egg collections and fertilization process is like first thing in the morning. So we're usually there around 7 a.m. and we don't leave in the day until all the work's done because obviously our work is time sensitive and you
Mhm.
can't just leave something and get it done the next day. So we're on a tight schedule. We're usually very busy and we're there for long days, but it's lots of fun and it's very varied. So as a trained scientist, you usually are responsible for one part of the process during a day. So you might be on egg collections, like I said before, searching through the fluid, looking for the eggs from the patients on that day, or you might be sitting down to do some ICSIs. So that's literally looking down a microscope and using micro manipulators, we call them. So that's what we control the tiny needles that will hold the egg and inject the sperm with.
Mhm.
Or perhaps you might be on, embryo biopsy, which is taking some of those cells from the formed embryos on day 5 and 6 and sending those cells off for testing so we could see what their genetic makeup is.
Yeah, okay, amazing. And just one quick question on genetic testing, because I think this comes up for people sometimes. When we're doing IVF, if you want to genetically test, you have to freeze your embryo. Is that right?
That's correct. Yeah. So there's a delay in receiving those testing results. So while we wait for those testing results to come through, we need to have the embryos frozen. So they're staying in that same state. Yeah.
Okay, so if you wanted to opt out of genetically testing, you could potentially have your transfer once you have a day 5 blastocyst, you could get that popped right back in.
That's correct. Yeah. So day 5 is the day we would do a transfer. In our lab, we would only transfer on day 5. If your embryo is suitable for freezing, maybe on day 6, it's now out of sync with your uterus. So we would actually freeze that one and put it back your next cycle.
Wow.
So day 5 is like when
Can't
your
believe
uterus
this.
is like perfectly ready to receive your embryo. So I guess there's a lot of factors at play and you need to make sure the timing's perfect on all of them.
One question I had, when you say genetic testing, is that PGT testing?
Yeah, that's
So
correct.
when
Yeah.
people say I'm doing a PGT test, it's that.
Yeah. So there's
And I was going to say, is there different types of PGT testing?
There is, yeah. So you could be genetically testing your embryos for multiple reasons. Most commonly, it's to make sure that there's the correct number of chromosomes in an embryo. So we expect there to be 23 chromosomes from the egg and 23 chromosomes from the sperm, so 46 in total. And when they test, what they're looking for is to see out of the roughly 5 cells that we send for testing, that those cells show the same number of chromosomes and being equal, and that 46 in each of those cells. So if you have gained or lost a chromosome in one of those cells, which sometimes happens, and it's consistently seen across those 5 cells, then it's going to report as saying, unfortunately, maybe extra chromosome 16 is found in these, and so therefore the embryo is not going to be viable. And I guess for a lot of people as well, that can be a handy thing if they're having recurrent miscarriages. So maybe they're finding that they can get implantation really easily, but those embryos aren't leading to a baby. Perhaps it's something that chromosomally is not there and it's not going to viably become a baby.
So when people say IVF decreases the chance of miscarriage, it's actually PGT testing that decreases the
PGT
chance.
testing does.
Because if
Yeah.
you're not testing and you're just putting an embryo in, you don't know what's going to
That's
happen.
that's correct. Yeah. And we especially because we know that they're good quality embryos too, so we have no reason to believe that those embryos shouldn't implant and they can do that, but if they don't have the right genetic makeup, they aren't going to make it past a certain point. Yeah. In development. Yeah. And I guess the other reason why you might test is if you have a specific disease of concern that you're worried about, or a condition that could be passed on, which is quite popular now as well. Is it's the way to make sure that the embryos that are chromosomally normal, because we'll check that too if we're doing this test, that they don't carry that condition that's going to affect them.
Yeah. I know a lot of friends who do that for the BRCA gene.
Yeah.
I know that's a big one.
Yeah, absolutely.
Okay, switching gears a little bit, what is your favorite part about your job?
I think it's definitely the patient contact. So I love being able to talk to our patients, both delivering good news, because that's obviously the best part of your day, but also being able to support patients who don't receive the good news and maybe have questions, or there's always questions in this process, and sometimes we don't have all the answers, but helping them feel supported enough or educated enough to be able to manage that disappointment is one of the best parts of my job. So
I feel like I just learned so much from you and I thought I knew a lot. This is a lot of new information. It's really interesting.
look, there's so much, and everyone's treatment is so different too. So sometimes a Google search will be perfect for one person's, outcome, but they'll be still missing information as to why it's relevant to that person. So I like being able to fill in those gaps.
Yeah.
Yep.
I think like comparison is a very big thing that comes up. And as fertility is becoming less taboo and we're having more conversations amongst ourselves and amongst our friends, a lot of comparison goes on. But we all have, I think, very unique fertility journeys and fertility issues potentially. And so understanding, like having these conversations with people like you and understanding that it is so individual, I think in itself brings a bit more of a sense of reducing that comparison to one another, because once you understand it's not a one size fits all by any means, I think it becomes a little bit more digestible for people.
Definitely. It's so individualized, and every egg, every sperm, every embryo is a little bit different, and that's just biology, and some of like we can do everything in our power to make sure that we have the best possible diets and exercise and lifestyle factors to ensure we're giving ourselves the best chance. But at the end of the day, there's still so much unknown biology that just comes down to chance and the differences between the human bodies, that it can't fit. One size definitely can't fit all.
Yeah.
Is it genetics or we don't know?
A combination. It's a combination of genetics, lifestyle, it all kind of works together. And I guess that's what makes it so uniquely different to each person.
Yeah, absolutely. On that, so obviously it's a very unique thing for person to person. Also, fertility is coming a really, really long way, really quite rapidly. So that kind of has us wondering what like future research are you fascinated by, and where do you think maybe the future of fertility and IVF is going?
Yeah, so it's probably going to end up in me being out of a job and replacing robots, but that's kind of unfortunately our job has a lot of reliance on human, technique, and I guess one of the things they're looking at the moment is how to standardize that, because within a lab you could still have different scientists that are at different levels of experience, different techniques slightly, that you might have those things interfering with results potentially. So what they're trying to do is standardize it by using robotics and automated processes. So they're definitely not there yet, and there's like a very long way to go, but I'm so sure that in the future there'll be a lot of robotics and that sort of processing. At the moment, we've already started using AI to help us select embryos. So in my lab, we have an embryoscope, which is it takes an image of your embryo every 10 minutes and then it puts that footage together in a video, which is so helpful for us for assessing. But at the same time, they've got a computer that's also assessing the embryo, and it's making a decision based on how the embryo develops and at which time points it's developing, and it'll kind of give a score on how likely it thinks that embryo is going to create a baby. So
And we
we're
trust
already
we
using things
trust
yeah, not yet. We don't even AI, we're not fully there yet. We still assess at the same time, and our decision trumps it, but I can see in the future, definitely. Yeah.
crazy.
Yeah,
Yeah.
that is absolutely mind-blowing to think that that is where we're going with this. But at the same time, like, IVF in itself is mind-blowing that we have the ability to even do this process is insane. So I can see that we're just going to continue to develop in that trajectory, which is, it's fascinating, really, really fascinating. And it's exciting for a lot of people because it brings, I guess, hope to a lot of people that there is a chance for people to have options when things maybe are looking tough for them in their fertility journeys. So I'm hearing a little bit more talk around the fertility word about maybe potentially being able to one day help immature eggs become mature. Is that something that you have heard about in different research studies and things like that?
Yep, definitely. It's a very complicated process, and it's hard to do with eggs that have come from a stimulated cycle, which is a lot of our cycles currently.
Yeah.
However, it's definitely something that could help potentially fertility preservation, which is can happen in a lot of cancer patients who kind of need like last minute free, like we find out about it now, it needs to happen. That's something that could potentially help those patients who don't have time to stimulate their ovaries and just kind of need to have a collection. So at the moment, immature eggs in the lab are just unusable and they get discarded. But yeah, they're starting to do a lot of research into perhaps being able to mature those eggs within the lab. And that could be life-changing for, a lot of patients who either can't go through the stimulation process or aren't getting a lot of eggs in the stimulation process. So
Essentially, when you talked about the process of stimulating eggs to be able to get to the point of doing an egg collection, I think what's confusing is people are like, well, where are all these eggs coming from? So obviously we generally, if we didn't do a stimulation process and we had a regular menstrual cycle, we would presumably release maybe one dominant follicle for that month, ovulate that egg, and then that goes out and potentially has the chance to be fertilized. So what is the difference? What is IVF doing to make all these other eggs come out of nowhere?
So you're exactly right. The dominant follicle is usually the one that will ovulate. Some people ovulate too, and then you get your twins. But what happens is although there's a dominant follicle, there's a whole heap of immature follicles at the same time. And usually in a cycle, the dominant one takes the lead and then the immature ones will just eventually kind of degenerate and finish off into nothing. But what the IVF process does is it stimulates all of those follicles and it grows them to be very similar to the dominant follicle. And then it will aim to have them mature enough, ready to go for collection at the same time. So we're manipulating what's naturally there in the ovary to try and collect as many eggs as possible from one cycle. Yeah.
Crazy world out there.
It really is.
I think we have one final question for you, which Alyssa is going to ask you.
We're asking all of our guests, what's got you scrambled in life right now?
Yeah, so it actually inspired me to think about it a little bit. But for me personally, this is like I'm 32 now, so this is, I'm in that peak fertility window where you've kind of got to decide what you're doing with your life.
Yeah.
But I find it really hard because for a lot of women, you go through your study or whatever it is, your training, you get into your career. About the time that your career is taking off and you're doing something, you've got to make a decision that, you're in that age of that reproductive age where you've kind of got to start making decision or at least being educated about what your body is doing so that you can kind of decide if you need to freeze eggs, which may be an option for you, or if you have a partner, perhaps you start looking at trying. So I had to do that myself and kind of assess what information was out there and what I needed to know. So, for example, like AMH testing, which I'm sure you'll cover in future episodes.
You certainly will. Don't worry. Those dreaded 3 letters.
Yeah. So, like, there's, I guess there's a lot of it's a bit taboo because a lot of people don't know what to do with that information once you get it. And sometimes it means a lot and sometimes it means nothing really.
Yeah.
And do you test for it or do you not? And that decision for me, I guess I did that testing. I found out the information. It wasn't the information I was expecting, so it was a little bit of a shock. And then I guess just being educated enough to find out, although my partner and I haven't started trying yet, we looked at if there was going to be any other hurdles in our way. So we did go and do some genetic screening just to see if we had any issues there that we needed to be aware of. So I guess if we did need to go down the IVF route, was there something else that could be in our way or a factor that we hadn't considered, just to make sure there wasn't going to be anything that was more difficult than just our regular kind of difficulties the older that you get. And I guess I'd recommend, even if you're not going to do anything, being educated with that kind of testing to know what it really means is super helpful. So
Yeah, I think that just sums up the whole reason that we started the podcast. We were like, we're having these conversations amongst ourselves. We're in the same age bracket as you are. And for us, we both got pretty confronting information when we found out our fertility estimates as well. So it kind of makes you, just having these conversations, I think is going to enable people to go and get themselves the same knowledge and to decide how to implement that knowledge into their life as well is,
And I think most people find it scary, the talk around fertility, but I am so grateful that I learned what I did when I did, because I was able to take action. And whether that means I need to use the frozen eggs in the future or not, it's security, and I feel better.
yeah, absolutely. It's almost empowerment in that way.
Exactly.
Like it gives you an option to have those decisions.
Yeah. So thank you for sharing that with us. I mean, this whole thing is about us trying to be vulnerable, share our own stories, talk to experts, get different people's opinions, just so that people can make decisions. They don't have to make the same decisions as us, but just so that they know what their options are and what all this means. It's a really daunting process for people, and there's only so many resources. Your IVF clinic can only support you so much. Unfortunately, I think we found that there was a lack of resources. So we're just trying to make sure that these conversations are out there for people. I think we've chatted about some really cool things that I think maybe some visual stuff would help. I think maybe some pictures and images of ICSI and stuff we might be able to post on our socials. Yeah,
that sounds great. And I think what you guys are doing is awesome, because like you said, the more information out there, the more people talking about it, it makes the whole thing less scary.
Yeah, that's the aim. I mean, God knows whether this will ever make it into an episode, but we will try.